Good morning, everyone. Well, I'll be talking about the tips in refractory vessel bleeding against the tips. But actually, there cannot be any debate regarding not using tips in patients with refractory vessel bleeding, because actually there is no other alternative apart from doing tips in these patients. However, certain limitations are there regarding the tips in this setting, and we'll be discussing what are these limitations and how can we improve these limitations. So, as discussed already, acute vessel bleed is an important event in the history of cirrhosis, with the mortality rates of 15 to 20% and have remained the same over the last 1 or 2 decades. And the guidelines have recommended 2 important endpoints. That is the failure to control bleeding, defined as treatment failure or death within 5 days, because the time frame of the vessel bleed is 5 days. And more important than that is the bleeding-related mortality, that is death occurring within 6 weeks, and which has been recommended as the primary endpoint by the recent Boveno guidelines, because patient can die of the complications of vessel bleeding despite having achievement of hemostasis. So failure to control bleed is defined as, by the apostle, the fresh hematemesis after 2 hours of the drug therapy and the endotherapy, 2-gram drop in hemoglobin, or the death. Any of these 3 criteria, if it's present, it signifies failure to control bleeding. As per the Boveno, with full medical treatment, 2 endoscopic attempts or 1 endoscopic attempt, but leading to the use of the balloon tamponade or the Denisella stenting as a form of rescue therapy. So RCTs of tips, 3 important areas have been studied thoroughly: the secondary prophylaxis of vessel bleeding, the treatment of acute vessel bleeding, especially the preemptive tips, and the refractory ascites. Coming to the portal hypertensive bleeding, prophylactic tips has got no role and has not been studied, as already discussed, because the risk is more, benefit is less. What is very important is the preemptive tips. It is actually the institution of tips after successful control of endotherapy, after successful control of vessel bleeding with the use of drugs and endotherapy. But these patients remain at high risk of failure to control bleeding, because the time frame of the vessel bleed is 5 days. So placing tips in select group of patients within 72 hours or preferably within 24 hours to prevent the failure to control bleed and to improve the survival rates in these patients. We use preemptive tips, but it is used in the selective patient population. And the other one is the rescue tips, that is when the bleed is not being able to control by endoscopy. So these 2 entities are different entities, preemptive tips and the rescue tips. Very few studies are actually there seeing the role of rescue tips in patients of refractory vessel bleeding. This study, published recently from the Royal Free Hospital, analyzing 144 patients, already has been discussed although, but certain points I would like to highlight there. The recurrent bleeding was seen in nearly 30% of these patients, and out of this, nearly half of these patients had a rebleed within 6 weeks of the institution of the tips. And these patients were fairly having high child score. 63 patients had child score 10 to 13, and 10 patients had child score 14 to 15. But interestingly, the bleeding rate was similar in the 2 groups. For the predictors of mortality, they analyzed 3 models. Model 1, taking into account the child score and the MELD score, and they found that the pre-tips ICU state was significant predictor of mortality at 6 weeks. In Model 2, they segregated the child score into its individual component, and they found that the MELD score, the pre-tips ICU stay, and the presence of ascites was independent predictor. In Model 3, when they segregated the MELD score, they found that the child score and the pre-tips ICU stay were the independent predictor of mortality at 6 weeks. Coming to the child score, as expected, the child score A and B had a better survival compared to child C. But what is more important is that 6-week mortality in child 10 to 13 was 29%, but it was 100% mortality in patients of child score 14 and 15. So despite adequate control of bleeding, these patients had a 100% mortality at the end of 6 weeks. So placing a big question whether rescue tips be even offered to these patients or not. So this one is a recent study analyzing the data from 6 European centers. Nearly 150 patients were there, and they found that despite adequate control of hemostasis, actually the 6-week rebleed rate in this study was only 15%. Still then the mortality rates at the 6 weeks were as high as 42%. As expected, the higher ACLF grades had higher mortality, and they found that the lactate more than 12 or the MELD more than 30 had a uniformly poor prognosis very poor survival rates at the 6 weeks, despite adequate control of bleeding. So these are the recent Boveno consensus guidelines, which have suggested that the failure to control variceal bleeding is although best managed by the salvage tips, and the recommendation is strong. It is B1. But it also says that tips may be futile in patients who are having child score 14 or 15, or MELD more than 30 or lactate more than 12, unless there is short-term prospect of liver transplantation in them. So this one is the study as already discussed. And what is more interesting in this study is that this is from our center, and out of 672 patients in the last 10 years, 66 underwent emergency tips, and very importantly, 31 patients actually underwent tips within 8 hours of the presentation, which is, I think, very impractical and can happen only in center like ILBS in the whole world. And nearly half of these patients underwent early tips from 8 to 24 hours. And the rebleed and the survival rates, the rebleed rate was very less, that is 1.5% at 5 days, and only 6% at the 6 weeks. But still then the survival rate was relatively not as good. The 6-week survival rate was 68%, despite adequate control of hemostasis. And when the data was analyzed separately, tips within 8 hours or 8 to 24 hours, it was found that the 6-week survival rate was as high as 87% in patients who underwent very early tips within 8 hours, and as high as 84% at 1 year. Such a good survival figures I have not found actually when analyzed the data of the tips, and it is really commendable. Coming to the predictors of mortality, one of the independent predictors of mortality was MELD sodium, and with the AU-ROC of nearly 0.95, and MELD 24 was the best cutoff, having a sensitivity and specificity close to 90% for predicting 6-week survival. Again, emphasizing that it is the baseline liver status which is very important in predicting survival. Patient can die of the consequences of the variceal bleeding if the overall underlying liver functions are not good, despite achievement of hemostasis. So this is published in the abstract form last year, ASLD, analyzing the predictors of post-tips encephalopathy, and in this it was found that the salvage tips was having a hazard ratio of 3.03 in predicting post-tips hepatic encephalopathy. This meta-analysis already has been discussed. Importantly, the 6 weeks survival rate was close to 67%, as we can see here. And when the data was analyzed separately, the non-covered bare tips and the before the institution of the tips compared to the covered tips and after the preemptive tips, the rates were similar. As we can see, 6 week survival 33%, 1 year survival, 1 year death close to 47%, and importantly, the death because of the rebleeding was only 8 to 9% in both the eras. Now, similarity in this could be because of the poor implementation of preemptive tips clinically, because they have been recently updated, and maybe in due course of time, preemptive tips will be more and more followed. And also the difference between the bare stent and the covered stent actually becomes important due course of time because of the neo-intramural hyperplasia, which in later course only leads to reduction in the diameter, functional diameter of the tips stent. Now coming to preemptive tips, I am discussing it here because it has already implication on the patients of salvage tips. As already discussed, the first study by Monaskilo, who included the HVG more than 20, and subsequently by the Garcia-Pagan, and later on a large number of studies have come, which have uniformly showed that preemptive tips in patient of child C improves 6 weeks and 1 year survival rates. As far as child B is concerned, the results are a bit heterogeneous. Some studies have favored that it improves the survival at 1 year, and some have not. So this is a recent meta-analysis taking into account the individual patient data, in which it was found that if we analyze the whole population, that is child B with active bleeding and child C, preemptive tips improves survival. Also separately, child B with active bleeding and child C, in both of these categories, preemptive tips improve survival at 1 year compared to the drugs plus endotherapy. However, when they analyzed the patients with child B thoroughly, they found that the child B equal to 7 with active bleeding was not having any advantage over the drugs plus endotherapy compared to child B 8 and 9, in which the survival advantage was there. So, in the recent Boveno guidelines, it has been recommended that preemptive tips should be applied in patient with child C less than 14 or child B more than 7 with active bleeding, or HVPG more than 20. Now, it has got important implications on salvage tips, because we know that patients of cirrhosis, as HVPG increases or the child score increases, the risk of bleeding increases. So, patient profile of salvage tips will change if we apply preemptive tips. Now, more and more patients of child C 14 and 15 will be coming for the rescue therapy, rescue tips, and outcome in them is already not good, as we have seen just now. So, HVPG increases, the child score increases, and in bleeders the HVPG is more, and in the non-bleeders the HVPG is less. So, if we apply the preemptive tips criteria, then more and more patients with child C 14 and 15 will actually be coming for the salvage tips. So, we need to improve the outcome in those patients. So, coming some basics about the tips and portal hypertension. According to the Poiseuille's law, the resistance to flow of blood or a fluid in the blood vessel is directly proportional to the length and the viscosity of the blood, but it is exponentially related to the diameter or the radius of the blood vessel. So, a mild change, minimal change in the diameter of the blood vessel leads to exponential changes in the resistance. So, when we apply tips, the portal cover gradient decreases. The beneficial effects are seen when the pressure is less than 12. But if the pressure is less than 10, especially in patients with high child scores, 14 or 15, there is always a risk of encephalopathy or liver failure. So, the margin of error is actually very less. That is, less than 12 is desirable, but less than 10 patients can have the harmful effects of the tips. And we know that if we use our 8 millimeter tips and underdilate it to 6 millimeter or to 7 millimeter, even this 1 millimeter difference can have huge implications, because the resistance is related to the fourth power of the radius of the blood vessel or the tips stent. Also, the timing affects the measurement of the portal pressure gradient. As we can see in this study, 36 patients required emergency tips, and the immediate portal pressure gradient was significantly lower than when it was measured at the 24 hours or when it was measured at 1 month after the procedure. So, it was advised by the authors of this study that the portal pressure gradient be measured after 24 hours of the procedure, so when the hemodynamics have been stabilized, although it may not be practical. The same group also studied the impact of deep sedation on the accuracy of hepatic and portal vein pressures. And in the awake state, they found that there was minimal variation in the hepatic vein portal vein pressures. But when the patient was in deep sedation, the respirations are very deep, and there are wide oscillations in the hepatic and portal vein pressures. And they found that when HVPG was measured in the awake state or in the deep sedation phase, there was not much difference. As we can see here, 16 millimeter of mercury in the awake state and nearly 15 to 16 millimeter in the deep sedation phase. However, when the HVPG and the portal pressure gradient was measured after the tips insertion, there was wide variation in the awake state vis-a-vis the deep sedation phase, the end inspiratory or end expiratory or the mean pressure cycle. So, they advise that the portal pressure gradient after the tips should be measured at least after 15 to 20 minutes when the effect of the sedatives are not there. Also, there is a common practice to underdilate the tips stent so as to achieve the useful effects of the tip on the same hand, avoiding the harmful effects in the form of encephalopathy or the post-tips liver failure. So, this is one study in which the Whitehouse stent 10 millimeter diameter was underdilated to 8 millimeter, and there was a progressive passive expansion of the stent, so that from the mean of 8 millimeter, it reached up to 9.4 millimeter by the end of 6 weeks. So, underdilatation of the stent also is not a very practical solution to avoid the complications of post-tips liver failure or encephalopathy. An important issue is that whether we should decrease the portal pressure gradient by less than 20% or we should reduce it by less than 12 millimeter of mercury. Because in patients who are having a HVPG of more than 20 or 20, reducing it to less than 12 leads to 40% reduction in the HVPG. And if we reduce it to 16, it leads to 20% reduction in the HVPG, and which can be very important in patients who are having very borderline liver functions. So, this is a meta-analysis in which it was found that even if the pressure is reduced by less than 20%, but if the final pressure remains more than 12, still the useful effects of the pressure reduction was there in the form of decreased risk of first bleeding or the rebleeding or the ascites or the encephalopathy or there was improved survival in these patients. Also, important question is whether the 12 millimeter or 20% criteria is valid for covered tips or not, because they have been tested for the bare stent tips and which tend to reduce in size in due course of time. On the other hand, the covered tips maintain this diameter for a long duration. So maybe, especially in patients who are having borderline liver functions, reducing the final pressure to 14 or 15 or reducing by 15% may be sufficient enough, especially to avoid the risk of liver failure or encephalopathy. So these are the expert recommendations which should be tested in future, whether in patients with the borderline liver functions, we can complement a small diameter tips with the drugs such as somatostatin or terlipressin, and because they too have got a synergistic effect by acting on different mechanisms of action. Tips bypasses the intrahepatic resistance and the drugs causes slackening vasoconstriction and decreases the blood flow. So their effect can be synergistic and may be especially helpful in patients with child score 14 and 15 or mild more than 30. Complementing a small diameter tips with embolization of the collaterals, especially more than 6 millimeter, so as to avoid the risk of post-tips encephalopathy and liver failure. And what is seen from our data, use of tips within 8 hours if the patient is hemodynamically stable, or if the patient is not that much stable, use of rescue Dennis-Ella stenting followed by early tips after stabilization, or the use of rescue tips followed by early liver transplantation, although it is usually very difficult to have liver transplantation very early. But this was a case report of 5 patients, and these patients were having refractory vessel bleeding, underwent salvage tips, they were having child score 14 and 15, and after a median duration of 8 days, these patients underwent liver transplantation. 6 months survival was 100% in these patients, compared to the other group where the similar patients, child score 14, 15, receiving salvage tips, did not receive liver transplantation. There was the 6 months survival was 0%. So to conclude, refractory vessel bleeding has a high mortality rate. Unfortunately, there is no alternative apart from the rescue tips in these patients. Preemptive tips will likely change the patient profile of rescue tips patient, because we will be seeing more and more difficult to treat patients in by tips. The rescue tips is associated with considerable mortality despite high rates of hemostasis. And further studies with the idea that we have just discussed now in the era of covered stents are needed.